All right, so now we're moving into chapter 28. So this is going to be the actual disorders of the hematologic and the lymphatic systems. So we're going to talk about your red blood cell disorders, we'll talk about your white blood cell disorders, we'll talk about your platelet disorders, and then we'll also talk about the spleen and what happens with that. So again, just like the previous chapter, I'm going to break this up so it's a little bit more palatable when you listen to it. And I'll try to do it by the actual cells themselves. So like your red blood cell disorders, I'll do all those together, but I'll make them a little bit smaller so it's a little bit easier to handle. All right, so the first thing we talk about is anemia. And we've talked about anemia this semester, even though we didn't really call it what it was. Anemia, what we're looking at here is we're looking at a deficiency of red blood cells, a deficiency of hemoglobin, or it's a deficiency of both. And anemia comes by a few different ways. So it could be that you have a production problem, so maybe the body doesn't produce enough red blood cells or hemoglobin. It could be a result of destruction. So it could be secondary to like chemotherapy, for example, that is destroying the red blood cells. Or it can be a true blood loss. So that would happen in a trauma where the patient lost a significant amount of circulating blood. So either way, whatever you want to call it, all anemias, even though they're caused by different things, the end result is still the same. You still have a reduced capacity to carry oxygen to the tissues. So all of the anemias are going to manifest exactly the same way, even though they are caused by different things. So etiologies with anemia, commonly what we tend to see sometimes, we can see this as dietary deficiencies. Most commonly what I think about with dietary deficiency is iron deficiency anemia. I teach that pretty strongly in pediatrics because it's very common in our peds population. But you can have dietary deficiencies in your adult population as well, especially if you have patients who are lacking iron in their diet. The big one that comes to mind are my vegetarians. The vegetarians have to be very cognizant that they a lot of times don't ingest your iron-rich meats. So instead, they have to get their iron from other sources. Other dietary deficiencies, you can have any of the B vitamins, B9, B12. All of those can be because you don't ingest enough, or I see that really commonly with people after they've had gastric surgery, or they have any kind of GI absorption problems. You may see some dietary deficiencies because they don't absorb the appropriate nutrients, okay? Hemolysis, so that's where the body basically attacks the red blood cells. So that could either be the body doing it itself, or it could be because of, like I said, chemotherapy is a big one for causing hemolysis. And then hereditary. So the big hereditary one that I'm going to talk about in this chapter is going to be sickle cell anemia. And so those are all the things that we have to be looking for when we have a patient that we suspect or confirm that has anemia. So signs and symptoms. So like I said, they're all, regardless if we're dealing with sickle cell, whether we're talking about aplastic, whether we're talking about iron deficiency, all the signs and symptoms are going to be the same because anemia means lack of oxygen-rich carrying blood. So your patient's going to manifest with pallor, okay? So remember from the previous chapter, like how do you assess pallor in a dark-skinned individual, okay? We look at the mucous membranes, we look at the palms and soles of the feet, okay? So we're going to look for that pallor. We may see manifestations of tachycardia, tachypnea, okay, because again, that's our body's attempt to compensate there. That irritability, okay, hypoxia. We're dealing with hypoxia issues here, so it's not uncommon for our patients to be restless and irritable. Fatigue. You may hear patients with anemia complain of chronic fatigue. And dyspnea. That's a very common symptom. So where a patient comes in with dyspnea, our first instinct is to automatically assume that it's respiratory or cardiovascular, but dyspnea can be secondary to a hematologic disorder, okay? If we're dealing with like a pernicious anemia, the patient may complain of numb hands or feet, maybe a sore tongue. Iron deficiency, they are also known for developing mouth fissures. Glossitis is that red tongue. A lot of times it looks very smooth, like there's no taste buds on it. That's what glossitis is. And we inspect the nails because iron deficiency anemia will give you that spoon-shaped nail, okay? So the way that we diagnose anemia is we have to do a CBC. Okay, so the CBC is going to show me what my red blood cell level is. It's going to show me my hemoglobin number. I also like to look at my hematocrit to see what my volume is. Bone marrow analysis, especially if we're looking for like aplastic anemia, bone marrow analysis, because that's where those red blood cells are made at. Okay, so we need to go look at the bone marrow and see, do we have something else going on? And we want to do tests to determine the source of bleeding. So if this patient is anemic because they have a GI bleed, then we would need to do a test to make sure of that, okay? So we do tests to determine whatever the source of bleeding is. Your therapeutic interventions, we're going to eliminate the cause, okay? So if it is a nutritional deficiency, we're going to do dietary changes or supplements, okay? If it is sickle cell, for example, we just have to be more cautious with going into very low anemia, and I'll talk about that in a second. If it is a true blood loss, okay, we may require surgery to fix the problem. Dietary changes, like I said, that's going to be specific to your iron deficiencies or your B vitamin deficiencies. Okay, you may have to consult a dietitian to see what kind of foods we need to add into their diet. Supplementation, the big one I think about is iron itself. This is something that they test on in the med-surg part of your ATI. This is also something you will see in pharmacology. What kinds of things do we have to teach our patients when we're doing iron supplementation? So we always encourage that they ingest it with vitamin C, for example, because it actually aids with the absorption of the iron. If it's going through like an IM injection, we always do a Z-track method, okay? If it is an iron suspension, for example, I have to teach this in pediatrics, they always need to drink it through a straw because it can actually stain the teeth. Okay, so supplementation, there's a lot of teaching that goes into the iron supplementation. And we may be required to do transfusions, particularly packed red blood cells, because if the dietary changes and oral supplementation alone is not enough, we may be required to do a blood transfusion as well. Nursing diagnoses for your anemic patients. Activity intolerance is a big one. Imbalanced nutrition, risk for injury, impaired oral mucous membranes, all excellent options for this patient. All right, and I'll do aplastic anemia in its own recording.